All right, I might get started for today. So, welcome everyone to our Pacific Digital Health webinar series. We've got a fair bit to go through, so I'll get started and we can hear all about HL7 FHIR in the Pacific and some practical use cases and how it's being implemented. So, we have an upcoming event. This is part of a webinar series. So our next one is going to be in February next year. We're going to have a bit of a break for Christmas and we'll be talking about the M-Supply suite of products. So pop that in your calendar to join us for our next one. In terms of today, what we're going to be going through is HL7 FHIR in the Pacific, some practical use cases. I'll be your host for today, Georgia Mulianga, and what we'll be going through is we'll have a presentation from Edwin talking about Tamanu as a distributed data model. We will then have a presentation from Rohan talking about HL7 FHIR materialization and management. We'll then hear from Mark, which will be some practical use cases of how it's being used in Palau at the moment. So it's actually already in production and being used there. And then finally, we're going to finish off with a presentation from Kate from CSIRO talking about FHIR terminology and how it's used in the Pacific. So without further ado, I'm going to hand over to Edwin to talk to us about Tamanu and a distributed data model. Over to you, Edwin.
Thanks, Georgia. So introducing Tamanu to people who, a lot of you will already know Tamanu and know about it. Some of you will be using it. If you just jump over to the next slide, Georgia. This is a screenshot from Tamanu. This is actually one of our latest interfaces. I think it looks really nice, like all of Tamanu, but of course I'm biased. So you can keep going, Georgia, and I'll talk about the reasons we built Tamanu. So it's an electronic health record that meets these 5 principles, which we couldn't find anything that previously did. Firstly, it's sync enabled. Obviously, across the Pacific, there are challenges with internet, and having something that works fully functionally offline and then synchronizes the data across the country is really essential. Secondly, it's free and open source. There's not much more to say about that. Desktop and mobile enabled, so it works both on the desktop computer and also for smaller health facilities, a stripped down version on a mobile app. There's comprehensive industry grade security. And it also interoperates with other systems, which is a lot about using HL7 FHIR and what we're talking about today. What makes it different is that it is, as well as all of those things, it's really modern. So we've just built it over the last about 6 years, and so it's using cutting edge tools, really modern technology, a great tech stack that's going to be really resilient for future changes as well. It's intuitive. We've really tried to design it with the thought in mind that you shouldn't need to be trained heavily in order to use it. You should be able to get in there and just go. It's very low cost. I spoke before about open source and free, and so the licenses are never charged. There is implementation and support costs if you opt into that, but they're much lower cost than the subscriptions and licenses for other softwares. And of course, what we're talking about today is the HL7 FHIR data exchange. Finally, it covers all clinical use cases and settings, so you can use one system for all. I'll talk now about the distributed data model of Tamanu. You can just skip over the screenshot, Georgia. So Tamanu is a system that can work across lots of different sites across the country. So it can work in hospitals, clinics, can be used in the field to be going out and doing roaming visits, so some of those outreach programs. And we want all of that to work offline, but we also want all of the data available everywhere so that the patient has a really coherent and consistent experience in the health system, and that they have continuity of care with all of their notes available everywhere. So let's start at Tamanu Desktop. This might be a user in a hospital or in a small facility entering notes and seeing a patient on Tamanu Desktop. And in that same facility, if you just click now, Georgia, you might have a bunch of other users also using Tamanu Desktop. All of them are connected to a facility server. Georgia, that's you again. Thank you. And so that means that all of them are in real time communicating with the same database. But because that server is available in their local area network, it is actually available offline. All of the functionality continues to work if the internet goes down. That then communicates with a central server, and that's over our sync mechanism. So our sync engine means that all of the data that's captured, whether it's online or offline in the facility server, can travel through into the central source of truth, the central server. And then that flows out, and there's another click here, Georgia, to other facility servers at other facilities around the country, where there will be other people using Tamanu Desktop, and also to mobile devices. So each mobile device can also store a subset of the data for offline functionality. So you can see we've got a bunch of users here across a whole lot of different facilities and desktop and mobile devices, and all of them can use all of the functionality offline and have a local copy of that data, which is why we talk about it as a distributed data model. Now, that has some implications with the integrations, where if you click once again, Georgia, we have external systems integrating, and they integrate by communicating with that central server. And that's because that central server has the canonical copy of all of the data. It's the source of truth. And so we use that HL7 FHIR protocol for those external systems to be able to get that data in and push data back to Tamanu as well. So the likes of a lab system, you can pull the lab requests across from the Tamanu system. So if someone on one of those Tamanu desktop devices submits a lab request, it flows into their facility server, it synchronizes to their central server, and then the external LIMS or laboratory information system can pull that data, that lab request through, and it will pop up automatically. And then when the lab request is completed and there's lab test results against it, then those will be posted back through to the Tamanu central server. They'll synchronize down to the facility server or mobile device, and they'll be viewable by the end user. So that's our distributed data model, both across within Tamanu and also distributing that data back and forth between those external integrations. And we've got a few of them at the moment. So we've got integrations with mSupply, with FHIR, DHIS2, MerlinView, OmniLab, Senite, Fiji Vaccination Registration System, and also with Telegram. And most of them use HL7 FHIR, which is a really scalable and consistent way to communicate with all of these different systems without having to build it again and again. So for example, OmniLab and Senite are both laboratory information systems, and they both use exactly the same API and exactly the same structure of data to communicate with Tamanu. If you can move on there, Georgia. So what is HL7 FHIR? Probably worth talking about that basic concept. It's the thing that defines how to communicate between two pieces of software in a health system. So it defines the standards that they use. It defines the resources that they can talk about. And a resource might be something like a patient, it might be an encounter, it might be an organization, which means the facility. So it defines all of those, and it defines the extensions. It allows for extensions as well where you need customizations. So it prescribes the language that they speak when two systems are talking to each other. It's also really modern. It's a REST API, and I know that some of you will know what that is and others won't, but it's the modern way that really large, like 95% of the internet is communicating over REST APIs, and it uses JSON as its data structure. It's also secure by design, which previous versions of HL7 and other frameworks were not, and it used modern security protocols for that. It's also human readable, so I'll show an example of that. If you go over to the next slide, Georgia, here's an example of HL7 version 2, and I don't know about you, I am a technical person, and I find that quite overwhelming. If you go to the next one, Georgia, this is HL7 FHIR, which is the new thing, and if you're not a technical person, you might still find that overwhelming. But for me, I can see things there. I can see that it says the subject display is John Yossarian. So I can immediately navigate through like a dictionary to the patient's name, and I can see the location, the physical type of a ward, and it's the antenatal. So you can tell that they're in the antenatal ward and in bed 1 if you go down to that bed section. If you found that overwhelming initially, you do get used to it. Now, humans aren't actually looking at this, But in terms of having developers work on it and communicating between different vendors about the structure that things should work in, having it human readable is really helpful for those technical people. But don't worry, if you use HL7 FHIR in your system, you'll never have to actually look at this. That's what we'll do. So you can move on, Georgia. So just talking about what's come out of HL7 and FHIR and using it. So it's a consistent single source of truth so that we don't have double entry across these different systems that can be different to each other. So our patient's name, for example, when Tamanu is used as the patient master index, the patient's name will be the same in Tamanu and in the laboratory system and in the RISPACs and in MSupply. It also is faster for clinicians, for health workers. They don't have to do that double entry, the manual entry themselves. And also it makes it more accurate because obviously if you have a computer communicating the data, it's not going to make any changes to that data, whereas a human may misread it or mistype it. You know, I make typos all the time, so it's more accurate as well. And also each user stays in their own system. So if you don't have an API connecting these things, what you can get is that a lab technician might need to jump over to the medical record system to be able to read the lab request and read the patient details, and then jump back into their lab system in order to fill out the tests and enter the patient details there as well. Instead of that, you have the nurses, the doctors will be using Tamanu as their medical record system. They'll enter the data in there, and the lab technician never needs to look at Tamanu. They stay in their system that they know about, they're comfortable with, and never need to swap over to Tamanu. Now, of course, there are also some pitfalls and challenges that we've dealt with along the way. So there's grey area in how you actually implement HL7 FHIR. There are performance challenges as you're trying to scale. You may as well go to the next one, Georgia. I'll talk through the ways that we've solved them as we go. So you can see those grey clouds have lifted. There's a beautiful sunny day because we now feel like we've got over most of those challenges. So in terms of the grey area, being early to adopting HL7 means that you can define some of the ways you're going to do things early. And you also, over time, you expand the scope covered in order to deal with the new cases that come up. There's also extensions built into HL7 FHIR, which allow you to customize it for some of those things that do come up. On the performance front, and a thing will pop up if you click here, we use materialization, which is something that Rohan is going to talk about in the next recorded session, piece. So I won't talk too much about that. Legacy systems, integrating with legacy systems is another challenge. And what we suggest there is you insist on FHIR. Actually, what we've had when we've had direct conversations with the people who create other systems, when we talk about the benefits of FHIR and they are already usually aware of FHIR and that they're going to need to implement it at some time, having that impetus of we use FHIR, you can integrate with FHIR, often encourages them to then make their system use FHIR as well. So even if it's a legacy system, that doesn't write off the ability to use FHIR, so long as the vendor is willing to invest in their own future sustainability. There's complexity involved in all of this as well. And so you have to be pragmatic. An example here is lab requests. There are a bunch of things that HL7 FHIR specifies you can handle, including some of the tests being added and lab technicians doing, now I can't remember the name, but there's something like rebound tests or ricochet tests. I'm sorry to the lab people out there. But we decided on the first pass to get an MVP out there that didn't support that because that was complexity that isn't used 99% of the time. And to just follow that saying perfect is the enemy of good. We're going to go for good and then iterate on that until it's perfect. And then lastly, stability. So you need a really stable system so that you can have these the requests flow through to these different between these different softwares in real time so that they actually can perform the clinical function appropriately. And really that just involves battle testing. So getting out there into real situations, putting the software to use and seeing where the weak points are and then improving them. And we've done a lot of that over the last year in particular, to the point where now we expect that most things get from the user entering them right through to the external software in around 2 minutes. And at the worst case, it can be sometimes 10 minutes, but generally it's within that 2 minutes, and that's perfectly reasonable for the clinical use cases we deal with. Yeah, thanks, Georgia. Now that's it from me. I'm happy to take questions, but we probably won't have time within this, so send them through afterwards and I can answer.
Thanks so much, Edwin. Yeah, if anyone has any questions, feel free to pop them in the chat and we'll be able to respond to them in there. Or alternatively, you can send us an email and we can respond to you there. I'm now going to move over to Rohan, who has pre-recorded a session for us just regarding FHIR materialization and management. So I'm just going to flick over to that and hopefully this works for us. Edwin, are you able to let me know if the sound comes through okay?
Hi everyone, my name's Rohan,
It's coming through,
and I'll
Georgia.
be taking you through how Tamanu uses FHIR. So the key features of FHIR in Tamanu are our materialization process, which Michael touched on a little bit earlier. And that's how we convert our internal representation of data into FHIR resources. Then I'll talk about the FHIR API, which is our implementation of a FHIR REST interface. And then lastly, I'll touch on the different resources that we currently support. So here's a bit of a diagram of Tamanu and sort of how we use FHIR. So before I see there's a bunch of different sort of nodes in this pipeline, but it's important to remember that everything sort of within this dotted boundary is just kind of part of the Tamanu application. And I've split things out to sort of draw some attention to where there are boundaries within our system, but from a user perspective, it's all kind of just Tamanu. But yeah, so on the left-hand side and in blue is sort of our internal application. So it's our facility servers and central servers and our application database. And whenever it's Tamanu talking within itself, it's all working within that world. And then on the right-hand side in orange, we have sort of our FHIR API and our FHIR database, which is what we expose for external applications. And you can see on the right there, that's Senite, one of our LIMS sort of integrations speaking to the FHIR API. So the Tamanu application will read and write only with the application database. And that's where that's the source of truth. That's where all the data in Tamanu is stored. And then you can see an arrow going between the application database and the FHIR database. And that's the materialization process. So you can see it's a one-directional flow. So data only goes from the application database to the FHIR database. And materialization is essentially like a form of replication. So we convert data from the format we use internally into FHIR resources, but it's a one-to-one mapping. There's no data that only exists in the FHIR database. It's all derived from the application database. And then you can see with the FHIR API, it only reads data from the FHIR database. So it never reads data from the application database, and it serves that data directly to external applications. Likewise, external applications only speak with the FHIR API. They never speak to sort of our other, I suppose aside from authentication, they never speak to other sides of our application. And when they write data, so let's say someone publishes results for a lab request from Senite and posts that into our FHIR API, that the side effects of that data are written to our application database. So even though the FHIR API only reads data from the FHIR database, it can write data to the application database, and that is how changes can come back into the FHIR database. So the results of that request will be written into the application database, and then those changes will be materialized into the FHIR database. So yeah, nothing aside from the application database sort of writes to that FHIR database. So here's the question is, why materialize? And I kind of like to think of it as why not, a couple of different why not. So what would our options be if we chose not to go with this materialization process? And one option would be to convert, convert our record format into FHIR resources at query time whenever people queried our FHIR API. And the main reason we don't want to do that is for performance. So the transformation queries can be quite complex. And so by pre-calculating them using materialization, we can return those requests quite quickly, whereas otherwise it would be very slow. And it also allows us to scale our API pretty efficiently. It would be a lot of load on the server if we were running those complex transformations all the time. But by materializing, we can kind of make the change once, and then no matter how many clients get, they can all read fairly quickly. So it allows us to scale better. And then I guess another option could have been, why not go FHIR native? So why not convert our internal representation of data to the FHIR schema? And now part of why we wouldn't have done that is because we already sort of had a lot of our internal representation before we started working with FHIR, so it would have been a lot of work to convert. But also by having our own application schema, we get a lot of flexibility in terms of the kind of features we might want to develop, the way we might want to interconnect those features. So it's nice for us to have a sort of mirroring of converting our data into FHIR resources, but not be so constrained that we can only work within what's supported in FHIR. So I do think we enjoy a benefit from that flexibility. So I'll jump through this slide kind of quickly because there's a lot of numbers and words, but I just want to give a sort of a visual representation of what this materialization looks like. So on the left, you can see our internal representation of data. And kind of importantly to note would be the fact that we reference things as you typically do in a database via like foreign keys and IDs. So we have the encounter ID, which is just a string, and then you have to look that up in the encounter table to get the information there. Whereas when we convert that data to FHIR resources, we end up with kind of the full resource at the end. So you can see the encounter there is structured the way like a FHIR encounter would be, and I've expanded out the category field here, so you can see a bit more that it really is a database representation of a FHIR resource. So now just a bit about the FHIR API. So essentially the way that our API works and the way that we encourage our clients to use our API is we're just a big FHIR database that they can read from. So the way our integrations typically work, let's say it's PMI, then the client will just poll the API on a regular interval, let's say every 5 or 10 minutes, requesting for any updates to the patient's resource. So they can just keep track of any new patients that have been created, maybe changes to a patient, their name has been changed or something like that. Each resource individually tracks the timestamp of when it was a change was last made to it. And so that's the basic polling that clients will do. They'll say, give me all the patients who were last updated since the last time I queried you. And that way you can just get the delta since last time. And then it's really up to the clients to sort of decide how they handle those changes. We do also support, on specific resources, we support posts. So for instance, for a lab request, in order to send results for a lab request, a client can post a FHIR diagnostic report, which links back to the service request, which they initially polled to get the lab request. And that will trigger the updates in our system. Now, currently we only support no resource that we allow posts for do we also allow gets for. So essentially it means that changes can't interfere between changes that happen on the the application side and changes that would come in from the client. So just a bit about which resources we support. Patient was probably the first one we implemented, and we use that across all of our integrations, PMI, LIMS, and RISPACs. Organization, which kind of maps to the different facilities that Tamanu might be running in, which is used by LIMS and RISPACs. Encounter for a patient encounter. Practitioner for users in Tamanu. Service requests map to both lab requests and imaging requests. And then for lab requests, you might also include a specimen. And then we have some custom immunization integrations as well. Awesome. Thank you so much.
Great. Thank you, Rohan, for that. That was a really good technical dive into HL7 FHIR. For anyone who maybe felt that was a little bit too technical, our next presentation is going to be another recorded one from Mark. And Mark is one of our project managers who implements Senite in Palau, and they actually have a FHIR implementation right now in Palau. So we're going to hear a little bit of how that looks on the user's end and what that looks like for our end users. So stay tuned just while I get this one going as well.
Mark, and I am the BES project manager for Senite, and I'm going to talk to you today about our integration between Tamanu and Senite, which we currently have in operation in the Bilao National Hospital in Palau, which I am actually coming to you from today. So first up, I'd like to talk about the data that will be set up across both systems. So in Tamanu, we use reference data. So this is to ensure that the all parameters are available for the requesting doctor to select and then use to create the lab request. So the reference data includes sample priorities, test types, specimen type, test panels, and also test categories. So once the data is created in Tamanu, we then need to ensure that it will also be able to be populated into Senite. So this means we have to configure the background settings of Senite. So this will include the sample priorities, and these will need to match what we have set up in Tamanu. And they will also need to match up what we have in Tamanu for the test types and also the panels. And along with all the background units, names, and laboratory information for each test, we will also need to add correct codes and keywords. And I will speak more about that in the later part of this presentation. Specimen types, we will also need to match up into Tamanu and Senite. And as you can see there, we have a serum config from Senite. And so what we have there is the prefix of SE, and that'll be used to match up the Tamanu code for that specimen type. And finally, we have test categories. So these are categories we use to sort or put the tests in Tamanu into certain categories. So then when they get added, they all get added as one request. So this can be based on which samples can run off, which tests, can run on which sample type. It could be by laboratory departments. It could be by clinically relevant categories of test types. And it could also just be up to the preferences of the laboratory. Now these categories actually don't need to match up into Senite. They can just be used in Tamanu to add the requests based on those categories. And then the other information that we'll need to come across is the patient and lab request information. So the patient information will be part of the PMI or the patient master index. And this can actually be integrated with Senite and doesn't have to be part of the lab request workflow. So this means that any new patient created in Tamanu, even if they haven't had a lab request created, can automatically be populated into Senite. And so the information that comes across with the PMI will be the patient name, their date of birth, their gender, and also their Tamanu or hospital ID, which will be unique to each patient. And then the other information that comes across with the request will be the requesting doctor. So this is obviously important, so we know where to send the results once they have been created in Senite. Now, we will have a population or a list of doctors in Tamanu, but this list does not need to get updated in Senite. If a doctor is not available on Senite when they create a new request, then Senite will automatically create a new contact for that doctor. I'd like to talk about the integration workflow. So we start off with the workflow with the clinician that creates the lab request into Manu. And then the laboratory will then use the active lab request function into Manu to go out and collect the samples based on which ones haven't been collected yet. Once they've collected it, they can then enter the collection details into Tamanu, and then they can transition the request into results pending. And then at this point, this is when the request will become available to Senite. So Senite will then fetch all the available requests, and then it will register them into Senite. So this eliminates the need for the lab assistants to do this. And then the laboratory will go ahead and do their normal testing, enter and verify the results. And then finally, they will end up publishing the report. And then the PDF report will then get sent directly to Tamanu. And then here the clinician can look at the report within the lab request. So with the integration, we have a number of workflow improvements which help the lab in particular to go about getting their results out a lot faster than they used to. So the first improvement is there's no need for the lab to print the lab request from Tamanu. They can just use either Tamanu or Senite to know exactly what the request has on it. And then throughout, there's also the PMI gets updated, or the patient master index. So this gets updated automatically now whenever a new patient is entered into Tamanu. This is even if they haven't had a lab request created. And there's no need to register the samples, as I mentioned. So over here on the right, we'll have the registration page, which Sahar mentioned, and this will be eliminated completely with the integration. Also the lab request statuses. So these are when the lab transitions the request from results pending to be verified or verified. This can be updated automatically in real time, and this allows the doctor to track the sample so they know exactly where the sample is and how long it may be for their results to be available. And then, as I mentioned earlier, the published PDF will be available automatically into Tamanu. Before, the lab used to download it from Senite and then upload into Tamanu manually. So that's a big improvement as well. So briefly, I'm going to talk about the lab request statuses. So these are the request status either in the lab request or within Senite, and this allows the clinicians and doctors to know where the sample is up to. So we'll have Tamanu specific statuses. These are to be collected and reception pending. So these are statuses that mean the sample has been requested or it has been collected, but it doesn't necessarily mean it's received into the lab yet. So the Tamanu and Senite status transitions include results pending. This is where the lab transitions it into be available for Senite to pick up the request. And this means that the actual physical sample has arrived at the lab. And then we have to be verified, verified, and published. And so these all obviously just transitions within the testing. And then we have rejected and invalidated workflows. So the rejection sample, you can see at the bottom screen here, this will actually automatically update into Tamanu when it's rejected in Senite. And we will also get a PDF notification sent over. So this allows the lab to select why the sample was rejected. And then it also informs the doctor about why it was rejected and if they need to go ahead and maybe order a recollect or create a new lab request. Okay, so now we're going to move on to an integration demo, which I'll show you how the integration works in real time. All right, so here we see Tamanu, and so this is from a lab perspective. So we go to the active requests, and down the right-hand side there, you can see all the samples that need to be collected. So we'll go down to our test patient, which is William Hiroto, and then we'll go into his lab request, and we'll go in and record the sample. So here we can enter the time and date the sample was collected. We can put collected by if we want to. We won't do that at this point, and then we'll put the sample type or specimen type, which is serum. And we can also put the site. So this is where the physical location on the body that the sample was collected. In this case, was probably drawn from the arm. Now you'll see it's transitioned to reception pending. So remember, this doesn't mean that the sample is ready for Senite yet. So we need to transition manually there to results pending. So this allows the lab to take control of which samples have arrived in the lab already and which ones haven't. And then, so automatically this request will get sent over to Senite, and we'll go down from the sample dashboard and we'll click on our request. And if you can see up here, we've got all the details from Tamanu. So we got the hospital and clinic, the sample type, the analysis profile that was selected by the doctor in question, and we've also got the site. Date of birth will be there, the sex of the patient, and also the Tamanu ID. So now we'll go through and enter our results for the thyroid function. So we've got T3, T4, and TSH results being entered here. And we'll just save and submit those. And then this will transition the sample to be verified. So you can see at the top there, it's to be verified now. And then you can also see here we've got results out of range. So we've got the T4 that is low, and then the TSH that is high. So we've got a automatic reference range, out of range result flag there for that. So now we'll verify the results, and then the sample automatically verifies as well. And then we'll go ahead and publish. So at this point, Senite is generating the PDF report, and this will be the report that will get sent out to the requesting clinician. And so we've got the logo of the hospital or lab, we've got the results, who entered the test, who verified it. And then right now we'll save it. So at this point, this is when we will get the status of the sample will transition to published, and the generated PDF report will get sent over to Tamanu. So we can now see in Senite, the sample is published. And if we go back over into the patient file in Tamanu, so we'll go back and find William. And then we'll go into their existing encounter and active lab requests. And you can see the status has transitioned to published. And if we go into the request, we'll be able to go view report. And the report from Senite will be there available for the doctor. And they have the option to download or print the report, whichever they want to do.
All right, I'm going to pause Mark there for a minute. It's really cool to see the way that clinicians only will have to use one software with these kind of integrations. I did just want to move on to our next presentation with Kate from CSIRO, and yeah, to talk a little bit more about how they're using FHIR in their context as well. So over to yourself, Kate.
Very much, Georgia. And will you move forward my slides from your end?
Yes, yep, I can move them along.
Okay. So hi everyone, and thanks so much for inviting me to come and give a presentation today. So just a little bit around who CSIRO are, and just the next slide. Thanks, Georgia. So CSIRO is Australia's national science agency. It's over 5,000 people. We cover state-of-the-art national research from all domains. In fact, you may or may not know that we were key to inventing Wi-Fi. Probably our biggest claim to fame, along with AirGuard, single-use contacts, and all these other things. But we also have a really strong role in digital health. Next slide, thanks, Georgia. So within Australia, CSIRO, through the Australian eHealth Research Centre, we operate the National Clinical Terminology Service on behalf of Australia. We also operate our National FHIR Accelerator. So we've seen lots of great examples around implementation of FHIR today. And within Australia, our role is how do we work together across the community with clinicians, government and industry to develop these foundational FHIR standards that you are seeing being implemented here, to make sure that we develop those fit for purpose for use within Australia. Also importantly, thanks to the Department of Foreign Affairs and Trade, we also, under the Partnerships for a Healthy Region program, have been funded to deliver a project called Strengthening Standards Capability Project. And that's really looking around how we can improve the adoption of standards and interoperability, so FHIR being that key standard in the Southeast Asia and Pacific region, to really ensure that we can mobilise and make access to quality, inclusive and equitable health data. Really, you know, if we can create seamless access to information, share that information between providers and providers, this really is something that underpins and enables supporting both communicable and non-communicable disease, and really supports that connected care health system that we're looking for. Next slide, thanks, Georgia. One of the key objectives around this, and we're working very actively, where we've kicked off within the Philippines and are now starting our discussions around how we can support work within the Pacific, around how do we really enhance and localize that expertise of standards development, so that across the region, within the Philippines and more broadly across the ASEAN region, developing and understanding how to implement these standards, standing up infrastructure to support the development, and looking at how to better analyze that data. Next slide. Thanks, Georgia. And that really is bringing things in around how do we look at training and how do we develop that training. So I saw lots of questions coming up around, questions around understanding more around FHIR. So fantastic to see the leadership and the adoption of FHIR. But how do you kind of push that message out and support that greater understanding, that greater awareness, that greater uptake around it? How do you look to how to localize these standards within the region, and what training can be provided? And also looking at standing up reference infrastructure to really lower that barrier for industry to adopt. And then really one of the key things about FHIR and the most important things about FHIR globally is FHIR is a global standard. It is mandated for use within the US. It's really starting to be mandated for use across Europe. Within Australia, we're actively underway, and in New Zealand, and there's strong, leadership to start to look at FHIR across the Pacific. And there's real benefit to having that one global standard, which we can all be part of that global community, because it really does mean that we can get best of breed implementations leveraging this standard, and those best of breed implementations putting their effort into building great user experience, rather than having to do the development effort around really localizing and customizing different bespoke implementations. Next slide. Thanks, Georgia. I won't go into this in detail, but some of the things that really, in terms of that training and where we want to look to work and how we can work with the Pacific community as well, and this is the program that we're leading within the Philippines, is first and foremost starting to look at, as I said, that training around those fundamentals. And we've heard a lot about FHIR today. And with FHIR is that exchange format. How do I know that the data that I'm exchanging problem information, I'm exchanging procedure information, I'm exchanging allergy information? Something that's really key to FHIR that we haven't actually spoken about today is actually the terminology, the language that underpins that information that we're exchanging. So if FHIR is like all the carriages on the train around, these are the different carriages of the information that I'm exchanging, then what's inside those carriages? What's that language? And this is where key, something like SNOMED CT, which is that global language of healthcare, how do we understand how something like SNOMED CT can be implemented? And so those first things we start around doing within our training within, currently within the Philippines, is really looking at training around terminology and training around basics around FHIR. And then how can you start to innovate on that? And this is where one of those real opportunities for innovation is around the use of something called FHIR questionnaires, which really is just how do I take a form and make that form interoperable. And so currently, if the systems are more paper-based questionnaires, assessments, referrals, how can we start to look at those being something that's more structured, that could be delivered on a tablet, on a device, to really make much more mobile, much more accessible, capturing and exchanging of really important healthcare information. And then importantly, once we've actually started to improve that recording, that capture, that seamless exchange of information, what can I start to do in terms of analytics? Next slide. Thanks, Georgia. And then one of the things that we're standing up within the sandbox under this program, and at the moment this is in Asia, and we are exploring how we can support this work in the Pacific as well, is in those things around terminology servers, data repositories, testing tools that can actually support a regional approach and a regional community to really leveraging, understanding how to get the best use of these standards, and also how to govern these standards within the region. Next slide. Thanks, Georgia. These are the kinds of things that, in terms of the FHIR lab that we're setting up, we're looking at having FHIR servers, FHIR terminology servers, some of the open source tooling. there's opportunity here where with Tamanu, Tapire, and all the other products we've been talking as well around how this can support to really create this testing and development and education environment. Next slide, thank you. That's it. So what I really wanted to talk about a little bit then is more about terminology. So as I mentioned, it's fantastic. FHIR is absolutely key to the exchange. But one thing that makes FHIR actually the most useful thing in terms of that data exchange is in the terminology that sits within it. So things like LOINC, which have already been mentioned, and LOINC around how LOINC supports pathology, laboratory information, obviously M-Supply and the role it has around supporting medicines information. But then when it comes to things like allergies and procedures, problems, starting to look at how something like SNOMED CT, which is a global language, it's adopted by a large number of countries around the world. 50 countries are key members to SNOMED International, that can really provide a standard language so that the way that diagnoses or problems are recorded within a system can be common across all of those systems. So instead of everyone having to kind of come up with their own subset list of problems or their own subset list of procedures, there's actually an opportunity to leverage a global standard to implement that, to be able to create local synonyms within your own regions, but still have that one interoperable set of terminology. That means it doesn't matter what system, or even within the one system, it saves you having to come up with and maintain those local code sets. There's lots of opportunity that while SNOMED is something that is a member-based organisation where countries and regions join up to SNOMED International, as part of SNOMED International's work around the International Patient Summary, there is a free set of SNOMED that can be used and can be adopted to support those things like International Patient Summary. And I think that's one of a really great starting point to say, well, how could we use a subset of SNOMED to start to support our procedures, our diagnoses, and our allergy information that provides that language in a way that clinicians want to speak, not the way that we want for classifications or reporting, but the way we as clinicians want to speak. How could that start to be adopted within these systems as well, to also start to support not only that common exchange format, but that common language to start to get the benefit of these globally agreed national terminologies. I'm very happy. I don't know if there's actually time to take questions, but I'm very happy to take questions, and we're really open to feedback around how we can work and support the uplift and the capability and development of governance around standards within the Pacific. So thank you very much for your time.
We may have lost Georgia. I know she was having some internet troubles today, so I'm going to take over. Now, I don't have the rest of the video that Mark was presenting earlier, but it's probably a good time to just open up for a few questions. So does anyone have questions? I can see there's some coming through in the chat here. Actually, no, I can't see any unanswered questions, but maybe I'll read through the questions that have been there. And in the meantime, anyone who has additional questions, just pop them in the chat or put your hand up and you can ask them. So that goes for any questions for Kate or myself or just across the board. So the first question was, what's the difference between FHIR and EMR? So the EMR is the system itself, the electronic medical record, and examples of that are Tamanu, Epic, Cerner, Orion, all of those different systems that allow you to track patients' medical journeys over time. And FHIR is the actual language that is spoken and the structure of that language between that EMR system and other systems in the overall health ecosystem. Too many times saying the word system. Other than that, the questions were just about whether we can get recordings of this. So yes, there's recording. There are recordings available, and they'll be sent through after this, and also the presentation, the PowerPoint can come through with that as well. So does anyone else have questions before we finish up? We've still got 10 minutes, so any questions at all? And no question is a silly question.
Sorry, can I ask one question?
Go for it.
Hi, good afternoon. I'm Pranil Maharaj from UNDP. Just wanted one, maybe again, as you said, maybe a stupid question as well. So in the region, what we are trying to do is we have multiple countries who are developing or using different systems. And what I was thinking is that if beyond essential, is there a plan that I know there is a lab system, there is another system for TB surveillance now we are talking about, and there is also now discussion on GIS mapping. Is there a possibility of having one platform where we can link this system together so that we'll have patient information system, the TB register or the TB patient's lab system linked to it, and then we map it on a GIS system? Thank you.
Yeah, Pranil, that's very far from a stupid question. That's a very strategic question, and exactly what we'd like to, as BES, be aiming for with both the FHIR integrations, but also the work that we do across the board. So, as you say, Pranil, across even within a country, but certainly across the region, there are lots of different systems. Now, FHIR is very appropriate to use to have a standardized way of communicating between those systems in most of the cases that you mentioned. Some of the cases may not be exact matches for FHIR, and the example there would be some of that GIS mapping, whether you want to do patient level information or whether you want to do aggregate information, that can determine whether you want to go for those FHIR resources or not. Is there a possibility of having one platform? The answer is yes, there is a possibility. And then to follow that up, there is a big challenge there as well. And so we do all need to pull together in order to try and make that a reality. And so in terms of platform, it's a little bit of an amorphous concept because platform can mean that it's the same actual software. But I think what you're getting at is that people continue to use the existing tools that they've got and that they link together through some other platform. Now, there are a couple of ways of doing this. One is a centralized integration engine, and that can communicate with the APIs of the different pieces of software. And that's an option, and it can work well, but you do need someone to maintain that centralized integration engine. The other option is for the different softwares to have a more distributed way of communicating so that the whole is connected, but there isn't a centralized mechanism for doing that. And adopting standards like FHIR and then some of the terminologies that Kate was talking about, SNOMED, CT, LOINC, do allow for that as well, so that over time, even if you don't have a single platform that is designed to unify across all of the others, you have a single way of communicating, which means that the individual pairings between all the different softwares creates this sort of organic overall system that is interconnected. It's a little bit of a waffly answer because it is hard and it is complex, but certainly love that thinking, and yeah, I think everyone here would be on board with trying to work together to do that. Do you have anything that I didn't answer there? Did that answer your question?
Yes, I think maybe we can have a side discussion and see how we can take this idea way forward. And yeah, thank you.
I realize I'm being very abstract and not concrete, and you probably want specifics. I will give you some specifics from within the BES software ecosystem. So we we support the like a suite of 5 softwares that are all interconnected and allow for those things. And we've worked to identify which software we think is the most suitable in terms of open source, free, robust, performant, and battle tested. And so Tamanu is obviously one for the medical record. We use Senite as our recommendation for the lab information system. For medications, we obviously use mSupply. For national data warehousing, we use DHIS2. For data visualization and aggregation, we use 2PIR. And so those are the 5. RISPACs we actually integrate with a few different options at this stage, so we haven't settled on the exact one that we would recommend there. But if you implement that suite of 5 tools, they do integrate with and interoperate with each other. And we can support those better than any others. Some of them we build ourselves, but most of them we've just found over time to be the best option. And those sorts of tools do exactly what you said, where not only do they interoperate, but the reporting at the end through to PIR allows you to aggregate the information across each of them and then present it in GIS maps. Now, I'm not sure which system the GIS system that you were referring to is, but 2PIR is an example of one that can certainly do that. But yeah, definitely sounds like there's plenty of material there for a side conversation. So Finlay has put a question in the chat. Is the endoscopy data recording system being integrated to Tamanu through FHIR and Tamanu? Is Tamanu developing it? I'm sorry, Finlay, I cannot answer that, but maybe the BES Melbourne office can respond in the chat there, and otherwise we can certainly follow up after the webinar. Probably got time for one more question if anyone has one. All right. Well, a couple of minutes early, we can finish up. Sorry that that Georgia had to drop off. She was having internet troubles already today, so I was always here as a backup. But yeah, hope you all enjoyed the webinar and got something out of it. If you do have any questions you think about later, please email them through. Always happy for that, and really glad to be engaging and building this community of people who work in this area across the region. Enjoy the rest of your day. Bye.